Well, I'm very pleased to be with everyone today to talk about insomnia pharmacotherapy. It's a big topic. There's a lot of history, there's a lot of future as well. And so we'll review a lot of that. Got disclosures. I have served as a consultant for ASI Pharmaceuticals and Purdue. Everything that I'm talking about is off-label, will be very clearly labeled as off-label. I do use a lot of brand names and historic images, but it's pretty clear that there's nothing that's directly promotional in this presentation. There are learning objectives. We're going to be reviewing key pharmacologic characteristics of the FDA-approved insomnia medications that allow customized therapy for patients. And that's really the key message that I have. We're in an era of personalized medication, and we have the opportunity to make a lot of choices with regard to pharmacodynamics, pharmacokinetics of medications. And so I'll be discussing a lot of those issues that really help us personalize our prescribing choices. We'll be talking about the mechanism of actions of the commonly prescribed medications. We'll be talking about investigational compounds as well. So let me go back into history, and many of you are immediately recognizing the Greek god Hypnos, god of sleep. And I figure if they had a god for sleep, it must have been for a good reason. I know that people right now will pray for better sleep, and I guess they were back then as well. I was roaming around the streets of Seattle several years ago and came upon this rather stunning representation among the other graffiti around there. And if you're wondering why I immediately recognized Hypnos, I don't know if you can see over my shoulder, I've got a big bust of Hypnos right here in my house. So I think that concern about sleep goes back a long, long way. There was an article that came out just about a year ago, and I'm going to show you that in a moment, suggesting that wine production goes back at least 8,000 years, and you can see this mosaic sort of representing the grapes. We got white grapes and we got red grapes already that long ago. So here it is, early Neolithic wine of Georgia in the South Caucasus, and so this was actual wine production, and I suspect that pretty early on people recognized that this would be useful for sleep in some cases. And in fact, I guess people still use some wine and other alcohol to try to sleep better. Here's a sleep log that a patient brought to me in 2006, and you can see he's going to bed about 7:45, and he's awake by 11. So he has some scotch, and then he goes back to bed, and he gets up at 4 and has some more scotch, and then he gets up 5:24 in the morning and has some more scotch, so he can sleep until about 8 o'clock in the morning. I would hope that most people don't use that, and in fact, alcohol usually backfires. It is sedating, but usually causes worse sleep later on during the night. I suspect as well that the soporific properties of the opium poppy were discovered, quite a long time ago, and probably had been used for millennia to try to promote sleep. And by the Middle Ages, there was use of laudanum, which was produced based upon the opium poppy. You can see in the graphic and in the drawing the poppies. And as the Industrial Revolution came along, there were a lot of products that evolved based upon opium. So what do we use now? And it's really quite a lot of things. It's a real diverse group of agents that people will turn to or get prescribed in order to try to promote sleep problems. And before looking at them in detail, I want to remind people that insomnia does not result from a hypnotic deficiency, no matter what patients may think sometimes, and plea for more and more and more. It's clearly not a deficiency. There's a role for hypnotic medications, but it's not because people are somehow deficient in those particular products. And still, while backing up before going directly into the pharmacotherapy of insomnia, I want to emphasize that education about sleep and mental health issues as well are an important part of the broad treatment approach. Healthy sleep habits are critical. Things that we describe as sleep hygiene are really the foundation of treatment. It doesn't make much sense to turn to, other therapies like medications, um, unless people are creating the right environment for their sleep. So we'll recommend regularity in sleep-wake timing. Make sure that people have an environment that's conducive for their sleep, their bedroom in particular. Clearly want to advise people about late in the day use of caffeine, alcohol, various other drugs that might have an effect on sleep. And clearly, we want to help optimize the management of other disorders, whether it's a mental health disorder or other physical problems or pain issues. Cognitive behavioral therapy is very beneficial for chronic insomnia. We may recommend adjustments in exposure to light and darkness at particular times. There's a recent product that involves cooling of the head, of the forehead, with an indication for treating insomnia symptoms. And then finally, there are, a whole lot of different medications. Some of them are sedating and directly targeting sleep. Some of them, in a more indirect sense, are able to facilitate sleep. So we'll move forward at this point and come up with a categorization. So I like to think of this grid as a useful way to organize all the different things that people may take to try to sleep better. And so you can see at the top, the differentiation is whether or not there is a formal indication, this would be by the FDA, for the treatment of sleep problems or insomnia. And then we also want to think whether or not a prescription is required for that substance. So we can put just about everything into one of these four grids. So here we are. Dietary supplements, they don't really have a formal indication for treating insomnia. You don't need a prescription for them. And there are an awful lot of them out there that are promoted for sleep. And so that's a large part of the pharmacotherapy of insomnia that people follow on their own. Then there are the over-the-counter sleep aids. And, with regard to sleep medications, it's really important to differentiate those that are over-the-counter versus the dietary supplements. So over-the-counter sleep aids are regulated by the FDA, and there are particular products that fall into that category. So we'll look at those more closely. We tend to think of over-the-counter as everything that you can get without a prescription, but with regard to sleep aids, it's good to remember that there are particular products that are in fact regulated. And then down at the bottom, requiring a prescription, there are lots of medications that are used off-label to try to treat insomnia. And then finally, there are those that are officially approved by the FDA for treating insomnia. So we're going to start by looking at these dietary supplements. And there are a lot of them are herbal preparations. There are homeopathic formulations, often falling into this category of complementary alternative medication. There really are two broad types. There's melatonin, and then there's everything else. Valerian would be one example. I put them in these two categories because melatonin, has real physiologic properties. It's an essential component of the regulation of our own sleep-wake cycle. It just happens not to be regulated at all in the US. That's not true in the UK, where it is regulated, but at least in this country, it's not regulated at all. There is limited efficacy data for the compounds in this category. Fortunately, there are a few safety concerns. And if you look around, there are just a huge, huge number of different products that fall into this category that are marketed as sleep aids. So I want to focus on melatonin for just a moment. It is a hormone. It's produced by our pineal gland. The timing is controlled by our circadian clock. And typically throughout the daytime, our melatonin levels are low. They gradually rise in the evening as our bedtime approaches. They're relatively high during the nighttime period when we're typically sleeping. They come down in the morning. And that's true for most of us who are able to be re-entrained by the photoperiod, the day-night cycle on a daily basis. However, some individuals who are totally blind may be free running on the time of their own circadian system, which may be a little bit longer than 24 hours. And these individuals will have melatonin cycles that don't line up exactly with the 24-hour clock. There's been a lot of research looking at melatonin, and the reviews suggest that it really doesn't do all that much for people when they're taking it at their bedtime. The greatest potential might be a few hours prior to bedtime. And the strongest evidence is for the use of melatonin in circadian rhythm disorders. And I show this to highlight the potential role that melatonin may have exogenously, but also the role that it has for us on a daily basis with regard to our endogenous melatonin. So this represents a 24-hour period from about 9 a.m. in the morning one day to the next. And you can see at the top are arrows, these downward arrows that represent the homeostatic drive for sleep. And our homeostatic sleep drive really represents the balance of how much we're sleeping. And so for whatever reason, as humans, we're driven to want to sleep about 1/3 of the time. So about 8 hours out of a 24-hour period. Purely from this homeostatic point of view, it wouldn't matter when that sleep was occurring, but we tend to do it at nighttime. And the reason is because of our circadian system, which is, physiologically driven. It's reinforced on a daily basis by the photoperiod. So looking at the top, you see the downward arrows from the homeostatic system are getting longer, meaning there is more of a sleep drive from the time we get up in the morning until we finally sleep again, and then it's reversed during the nighttime when we're sleeping. But that's not usually what we feel. We don't feel progressively sleepy from the moment we get up. Rather, what typically happens is we're okay in the morning because there's not much of a homeostatic sleep drive because we just slept. But then as the day goes on, by early to mid-afternoon, a lot of people, have that slump and alertness around siesta time. But if you stay awake and keep busy, by late in the afternoon and into the evening, people typically will feel more awake and alert. And that's because our circadian system is promoting maximum arousal in the evening. So that is what is helping us to stay awake and be active for 16 hours or so, while then sleeping for about 8 hours. And so while the homeostatic drive is determining about how much sleep we need, it's our circadian system that is optimizing our ability to achieve that sleep at nighttime. So those upward arrows from the circadian system that are keeping us awake in the evening quiet down as bedtime approaches, and that's because our melatonin is coming up in the evening, interacting with the melatonin receptors and the suprachiasmatic nucleus, quieting down that arousal, facilitating our ability then to fall asleep because our homeostatic sleep drive then is unopposed. So that's what melatonin is doing for all of us, internally on a daily, nightly basis. And by adding some melatonin earlier in the evening, there's some potential that it will facilitate that process by quieting down that circadian arousal more. At least that's what the theory is. Well, then there's the other category of the rest of the dietary supplements. I'm not going to read through all of these, but you can see there are a whole lot of different compounds, mostly plant products. Sometimes there are minerals that are added in. Oftentimes melatonin is added as well. A lot of these products have 1, 2, 3, 4, 5, or even more of these compounds together in the products, these dietary supplement products that are marketed for sleep. I want to emphasize these are not regulated by the FDA. There are questions about the purity and the concentration and the toxicity. There have been studies done that show that sometimes these products really don't have what's in the label, or certainly not in the concentration. On the other hand, I think that there are legitimate companies that do make, say, melatonin, for instance, some of the others exactly as would be in the label. Well, next we move to the over-the-counter sleep aids. And as I mentioned, this is a very well-defined category. It's not everything that you can buy without a prescription. So these are regulated by the FDA for their exact competition and their dosing and their manufacturing and their labeling and their marketing as well. And so these can be trusted for exactly what they are. So all of these are antihistamines. There are branded products out there. There are huge numbers of generics. And these tend to have a sedating effect, although people may develop some tolerance to that sedating effect. We're familiar with these products that are either sold alone or very often combined with analgesics. And also, they're the same products that might be prescribed at higher doses, but these lower doses are available in these over-the-counter preparations. So as I mentioned, all of them are antihistamines. Most of them are diphenhydramine. Some of them are doxylamine, and that's it. You can see the peak concentration usually is a few hours after taking the medication. And you can see as well that the elimination half-lives tend to be rather long, 8 hours, 10 hours, roughly. It depends, a lot on the individual and their age, how quickly they will metabolize them. But the bottom line is they tend to hang around for a long time. And so next day sedation may be a problem. So as antihistamines, obviously, they have antagonist activity at the histamine H1 receptor. Histamine itself is a potent stimulating neurotransmitter, so it makes sense that blocking that can have a sedating effect. With these particular medications, they have other effects as well, and probably the most problematic would be the muscarinic acetylcholine receptor antagonist activity. So that can cause some of the common side effects that go along with these medications. And again, I'll highlight the fact that there can be tolerance to sedating effects with daily use. Occasional use is probably fine when people are taking these on a nightly basis. Over time, they may not work as well. I saw a patient 2 weeks ago in our sleep disorders clinic. This young woman had been taking diphenhydramine, and you probably know that typical over-the-counter doses might be 25 to 50 milligrams. And over a long period of time, she had worked her way up to some nights taking as much as 600 milligrams of the diphenhydramine, and even that wasn't working for her. No surprise, sedation is a common side effect, and the potential anticholinergic effects as well. So as I mentioned, residual sedation due to the long half-life can be a problem. People feeling groggy the next morning. More problematic are the potential anticholinergic effects. I have seen individuals floridly delirious, very confused because of their use of over-the-counter doses of diphenhydramine. I've seen people, particularly older gentlemen, go into complete urinary retention, again, using over-the-counter doses of diphenhydramine. There may be a dry mouth, blurred vision. There's a warning about narrow angle glaucoma. So the greater risk here is with elderly individuals. I think we should be cautious with any older people who are using these antihistamines because of the anticholinergic effects. And it may be a problem as well for people who are taking, other medications that do have anticholinergic properties. That includes some antidepressants, antipsychotics, and a wide variety of others as well. So it's worth keeping in mind. The next category then would be those medications that do have sedating properties that are prescribed off-label. There are a lot of them that have been used at different times in different doses. So there are antidepressants, and I can hear you thinking trazodone, and more trazodone, and even more trazodone, and then maybe some mirtazapine in the old days, maybe some amitriptyline, a few others. Antipsychotics, yes, you're thinking quetiapine there. Anxiolytics, so there are a lot of benzodiazepines that are available, but not officially indicated for treating insomnia. So sometimes people will be on clonazepam, alprazolam, lorazepam, various others. Antihistamines may be prescribed, anticonvulsant mood stabilizers, for instance, gabapentin is a possibility. Antihypertensives, clonidine, anesthetic agents. Well, propofol, not used very successfully and tragically in some cases, although there is some interesting research going on with that. So key issues are, do these actually work for insomnia patients? Obviously, these are medications that are approved and they've been studied, but they've been studied for other indications, so it's not clear whether or not they really work for insomnia. They haven't been evaluated for safety in insomnia patients, which may be very different from, say, psychotic patients who might be taking quetiapine. So there really aren't good prescribing guidelines for these for individuals who are suffering from insomnia, and we really don't know that much necessarily about the sleep effects. Now, clearly, if somebody's got some comorbid condition, whether it's an anxiety disorder, a mood disorder, psychotic disorder, maybe it makes sense to combine the treatment and use a sedating medication. On the other hand, sometimes it just makes more sense to use two different medications because you'd have more flexibility that way. So antidepressants, there is that question of whether or not there is psychiatric comorbidities, because a lot of times these medications, trazodone in particular, may be prescribed for individuals who don't have any comorbidity of a mental health disorder. The sedation for these medications probably comes from a combination of the serotonergic muscarinic histaminic receptor blockade. And so we've got these risk benefit questions about the population of people who might be taking it for their legitimate indication versus those who may be taking the medication just to try to sleep better. And so here's trazodone, amitriptyline, mirtazapine. Doxepin as well has been used a lot over the years. I put an asterisk here because, as we'll see, there also is a doxepin product approved for the treatment of insomnia. I want to drill down a little bit more on trazodone just because it's used so commonly. It's got a moderately long half-life, which is biphasic, onset 30 minutes to 2 hours. I'm not going to read through all these receptor effects that you can see, but I just want to make the point that there are a lot of interactions that trazodone has, both mostly postsynaptic, but presynaptic as well. At the top, the 5-HT2A receptor antagonism probably has a lot to do with the sedation. Further down, the histamine antagonism likely as well. Long list of potential side effects: dizziness, hypotension, is a common problem because of the alpha-1 receptor blockade. So be cautious in older individuals, people who are taking other antihypertensive medications, sedation, headache, sweating, arrhythmias, priapism, not very common, but can be a very serious condition. Serotonin syndrome should be kept in mind as well, particularly when people are taking other serotonergic medications. And then one last thing to keep in mind is the fact that an active metabolite of trazodone is MCPP, which tends to be agitating. And so you shouldn't be tempted to go up and up and up and up on the dose of trazodone. A lot of people may prescribe 25, 50, 100, 150, but you don't want to go up and up and up purely to try to chase the sedating property, because it may backfire as you run into the adverse effects that may come along from the active metabolite. Antipsychotics, I think it's a bit more problematic here, even more so than the antidepressants, because of the potential adverse effects that go along with this whole class of medications. A risk-benefit ratio decision coming out of treating a psychotic person is very different from that risk-benefit conclusion just for someone who is being treated for insomnia. As I mentioned, quetiapine would be the most common one in this category by far, but occasionally some other antipsychotics are used. So lastly, we come to the category of the FDA-approved insomnia medications, and these are easily organized into 4 pharmacodynamic categories. The largest category would be the benzodiazepine receptor agonists. This is the oldest category and by far the largest. Some of these and the earlier ones are actual benzodiazepines based upon their characteristic structure. Then there's a newer generation of non-benzodiazepine hypnotics that work in a similar fashion but have different structures. Then there is a single selective melatonin receptor agonist, that's Ramelteon. There is a single selective histamine receptor antagonist, and that's the low-dose formulation of doxepin. And then finally, and most recently, is the dual orexin hypocretin receptor antagonist, and that is suvorexant. And this is the first slide showing all of the FDA-approved insomnia medications. So these are the ones that fall into this category of the benzodiazepine receptor agonist hypnotics. And at the top you see the benzodiazepines themselves. All of them are immediate release. There are 5 of them: midazolam, flurazepam, quazepam, temazepam, triazolam, sometimes still prescribed. You can see the brand names, which some may be familiar, the available doses, and then finally the elimination half-life for these. And a quick glance there shows that these are extraordinarily long in some cases, in fact, even a few days. So it's problematic when people take a dose and still may have a sedating effect the following day, but much more worrisome are those cases where people are taking nightly doses, and by the time they reach their steady state, it doesn't make much difference in terms of the blood level, whether it's daytime or nighttime. Somewhat shorter, you can see the triazolam temazepam a bit longer than that. A lot of variation in individuals. So those came out in the 70s and 80s, and then by the 1990s, the newer generation of what we call the non-benzodiazepine hypnotics came along. So the fundamental compounds are S-zopiclone, Zaloplan, and Zolpidem. Came out in the 90s and into the mid-2000s. Familiar brand names that have been heavily advertised over the years. You can next see the different dosages that are available. And then over all the way on the right, once again, you see the elimination half-lives. And, you know, the first conclusion is, wow, these are a lot shorter than a lot of those older benzodiazepine hypnotics. Well, that's a pretty good thing because there's less risk of sedation the next morning or later into the daytime. You might then ask a question, well, do these medications last long enough? And, you know, that really depends upon exactly what your aim is. So they range from about a half-life of an hour in Zaloplan, a little bit longer for the Zolpidem, about 2.5 hours. The S-zopiclone, about 6 hours, somewhat a bit longer in elderly individuals. You know, what's nice about this is we have choices and can select a medication. If somebody purely has sleep onset difficulty, then a shorter half-life is going to be satisfactory. If you're trying to take care of middle of the night awakenings, early morning awakening, then something with a bit longer half-life, but preferably nothing that's going to linger further into the daytime to cause excessive sleepiness or impairment. So Zolpidem also is available in a bunch of different formulations. The first one that became available, other than the immediate release, was this extended release preparation. You can see the available doses. The elimination half-life is about the same because it's the same molecule. It's simply that the blood level remains higher a little bit longer during the night because of the way that the pill is structured. And then finally at the bottom, there are 3 different alternate delivery systems for using Zolpidem. There's an oral spray, and 1 spray is 5 milligrams and 2 sprays is 10 milligrams. Elimination half-life is the same because it's the same molecule. The idea is, well, you don't need water to swallow a pill, and maybe it'll be absorbed quicker in the mouth, and therefore you have faster onset of action. I'm not sure that that's really true. Similarly, there is a sublingual dissolvable version of Zolpidem, also 5 and 10 milligrams, same half-life. The idea is that, well, you don't need water for it, and maybe it'll act quicker being dissolved in the mouth, but I suspect that a lot of the action still is due to it dissolving and going into the stomach and getting absorbed into the system that way. Then the third option is a bit different. This is also a dissolvable formulation that is specifically designed for middle of the night use. It is the only one of these, at least has the indication from the FDA for middle of the night use. These are very low doses. 1.75 milligrams is recommended for women, 3.5 for men. And you're supposed to be able to use this for a middle of the night awakening, assuming that another 4 hours are available for sleep, for it to be of some benefit, but more importantly, to be metabolized so that you're not left with any impairment from the medication when you get up for the day. So those are all of the benzodiazepine receptor agonist hypnotics approved by the FDA for treating insomnia. Here's where they work. It's the GABA A receptor complex. It's one of these 5 subunit transmembrane structures. Usually, but not always, there are 2 alpha, 2 beta, 1 gamma subunit. And you can see that GABA itself has a particular receptor site. And when GABA attaches there, it allows those chloride ions to enter the cell. So GABA is the most widespread inhibitory neurotransmitter, and so it makes sense that it's able to sort of modulate activity in the cell membrane, ultimately having an inhibitory effect, which is good to balance stimulating effects from other systems. So there is a separate, an allosteric site where a benzodiazepine can attach. And when that benzodiazepine is attached, it allows more of those negative chloride ions to enter the cell. So basically, it is, in a positive sense, enhancing what GABA is normally doing there. And so it brings about an enhanced inhibitory effect. There are a lot of medications that work at that site, a lot of different benzodiazepines. So we're interested in the hypnotic effect, but there may be a muscle relaxant effect, anticonvulsant effect, anxiolytic effect as well. All of that, all of those sort of sharing that enhancement of the inhibitory action. So the benzodiazepines, and we'll look at the non-benzodiazepines on the next slide, but pharmacodynamically, these are positive allosteric modulators of GABA responses at the GABA A receptor complex. So that's what we just looked at, positive, because it's doing enhancing what GABA normally does. It's allosteric because it's a separate site from where GABA attaches. There are a lot of different subtypes of the alpha subunit, and the benzodiazepines themselves seem to interact with a lot of those, and that's in contrast to the non-benzodiazepines. And while there may be global effects throughout the CNS because these receptors are pretty widespread, there also is targeted action in the hypothalamic sleep nuclei. So there are broad effects, but there's probably something special that's happening in the hypothalamus that's helping to influence the sleep-wake cycle. Pharmacokinetically, these are all relatively rapidly absorbed, so that's good for sleep onset. They vary quite widely in their elimination half-lives, as we've seen, from hours to even days. We should expect a prolonged half-life in older individuals. Most of these are beneficial for sleep onset and for sleep maintenance, but of course, with the long half-lives, there is potential for daytime sedation. So here are the non-benzodiazepines. This is very similar. They're the same positive allosteric modulators, but they're somewhat more selective in the GABA A receptor alpha subunits. Some people hypothesize that this leads to, somewhat greater safety with this class of medications. Still, there's that targeted action in the hypothalamic nuclei, global CNS effects. All of these are pretty rapidly absorbed, so reasonable for sleep onset. They have somewhat shorter elimination half-lives, as we've seen in adults, from maybe 1 to 6 hours. Still, we should expect prolonged half-life in older individuals. And for women, for Zolpidem, because they tend to metabolize it more slowly. There's another slide coming up about that fact. The indications vary for sleep onset and for sleep maintenance. And because the half-lives are shorter, there is less of a potential for problematic daytime sedation. But still, these medications, all have a lot of potential problems. There may be the residual effects lingering into the daytime, dizziness, headache, somnolence, blurred vision, nausea, diarrhea, fatigue, ataxia, particularly within a few hours of taking the medication. Anterograde amnesia is predictable from any benzodiazepine medication. So people may take a benzodiazepine, non-benzodiazepine hypnotic, and before they fall asleep, may not remember conversations that they have. And there is a potential, and it's highlighted in the PI for all of these medications, potential for somnambulism, complex sleep behaviors that may occur with these. In 2013, the FDA issued this drug safety communication warning, and they recommended lower doses of Zolpidem for women due to slower metabolism, possible excessive blood levels the following morning. So they recommended 5 milligrams should be the starting dose for the immediate release, 6.25 for the extended release. And they said, while you're at it, you might as well think about lower doses for men because they may be just as effective. The one exception here was that middle of the night formulation because the differentiation in the prescribing guidelines for men and women already was part of that label. Well, the next year, the FDA, being very concerned about next morning effects, came out with this drug safety communication regarding azopiclone. They recommended lower initial doses for men and for women at 1 milligram. It had been that 3 milligrams was the standard starting dose, and then the lower 1 or 2 milligrams, depending upon the individual, certainly lower doses for older individuals, but they're suggesting start at 1 milligram for everybody. And they said the previously recommended dose of 3 milligrams can cause impairment to driving skills, memory, and coordination that can last more than 11 hours after receiving an evening dose. And they went on to say dosage may be increased to 2 or 3 milligrams at bedtime with caution. Well, here are the other 3 medications that are approved by the FDA for treating insomnia. There is the selective melatonin receptor agonist, that is Remeltion. There is a single dose, it's 8 milligrams. The reason is because there is a flat dose response curve. And so larger doses, smaller doses really don't seem to make that much difference. The elimination half-life is relatively short, although that's less of an issue, say, compared to the benzodiazepine type of medications, because the melatonin system medications really are sending a signal to the circadian clock more so than directly promoting a sedating effect. Then there's the selective histamine H1 receptor antagonist. We've mentioned that. That is doxepin at pretty low doses, 3 and 6 milligrams. Pretty long half-life, about 15 hours. On the other hand, these are pretty minuscule doses, so hopefully not problematic the following day. And then most recently, there is the dual orexin receptor antagonist, that is suvorexant, available in 4 doses, half-life of about 12 hours. We'll look at each of these in a bit more detail. Remeltion. So this pharmacodynamically is an agonist at the melatonin MT1 and MT2 receptors. These are in the suprachiasmatic nucleus of the hypothalamus. And sort of as I've talked about what happens with melatonin itself, it can help reduce the evening circadian drive that brings about arousal. Interaction with these receptors also reinforces our circadian periodicity, sort of in the way that melatonin endogenously does. And because of the mechanism of action, it can enhance sleep onset, not so much by sedation, but by reducing the circadian arousal. Pharmacokinetically, it's pretty rapidly absorbed. There's a relatively short elimination half-life. The indication from the FDA is for sleep onset difficulty, so this is not your first choice for somebody with early morning awakening. And there's very limited potential for residual daytime sedation. So as I mentioned, the indication is for insomnia, characterized by difficulty with sleep onset, pretty well tolerated. Somnolence, dizziness, fatigue are in the label as the more common adverse effects. No abuse liability, so it is not considered to be a controlled substance. Should be avoided in people who have moderate to severe hepatic impairment or people who are taking fluvoxamine at the same time, because that is a potent inhibitor of the metabolic pathway in the liver that breaks down Remeltion. And I'll just show you this slide once again. What the Remeltion presumably is doing is helping to quiet down that circadian arousal in the evening and to help facilitate sleep onset. There's a low-dose doxepin, and pharmacodynamically, this doxepin at these really, really low doses is mostly an antihistamine, a histamine receptor antagonist, and avoiding a lot of the other potential effects that it may have at a higher dose. So as I mentioned, histamine itself is a potent wake-promoting neurotransmitter. It makes sense that blocking that is going to have a sedating effect. And so the doxepin is able to enhance sleep by reducing histamine arousal during the nighttime, especially later during the nighttime. Pharmacokinetically, it's pretty rapidly absorbed. Elimination half-life is moderately long at 15 hours, but once again, it's a low dose. It's in people's system towards the end of the night, and therefore the indication is for sleep maintenance difficulty. Very low potential for daytime sedation with that. So its indication is for the treatment of insomnia characterized by difficulty with sleep maintenance. You know, it might help people with sleep onset, but the indication is specifically for sleep maintenance. It was approved by the FDA for depression, 1969, and 2010 for insomnia. The doses for depression, the pills go as high as 150 milligrams, prescribing guidelines up to 300 milligrams daily. For insomnia, it is 3 and 6 milligrams. And again, that's because it is primarily an antihistamine effect, a cleaner antihistamine effect at these low doses. Low abuse liability, so it is a non-scheduled compound. Most common adverse effects during the clinical trials were somnolence, sedation, nausea, upper respiratory tract infection. And then the last one, suvorexant. It is a dual orexin receptor antagonist. There are hypothalamic neurons, which are peptides, producing these peptides, Orexin A and Orexin B. They're very similar. They have projections up to the cortex and down into the brainstem to a lot of wake-promoting nuclei. And this orexin system helps promote waking, stabilizes wakefulness, reinforces arousal. And suvorexant then promotes sleep by decreasing this orexin-associated CNS arousal. Pharmacokinetically, it's pretty rapidly absorbed. The elimination half-life is about 12 hours, and there is dose-dependent potential for residual daytime sedation with this medication. So the indication from the FDA is for the treatment of insomnia characterized by difficulties with sleep onset and or sleep maintenance, approved in 2014. The one contraindication is narcolepsy, because curiously, people with narcolepsy have very low orexin activity to begin with as part of the pathology of the disorder. The main adverse effect would be somnolence. It is classed as a Schedule 4 controlled substance. So there are a lot of ways to slice and dice all of these approved medications. Here's a list of all of them on the left, and you can see in terms of the approved indications, some of them are unspecified. Most of them are potentially beneficial for sleep onset, a lot of them for sleep maintenance. A few of them have listed indications for early morning awakening. A lot of it makes sense. The Romeltion you can see for sleep onset only, the low-dose doxepin you can see for sleep maintenance only, and a lot of the others make sense in terms of their elimination half-lives. And we can also look at these in terms of the DEA class. What's a controlled substance? You can see just about all of them. Only Romeltion and the low-dose doxepin are considered non-scheduled agents. Pregnancy category, that's easy to differentiate as well. All of those that are actual benzodiazepines are considered pregnancy category X, and everything else falls into the C category. And then a quick glance at the most common side effects. I see lots of somnolence and drowsiness and dizziness, and there are a few unique features that go along with some of the medications, but in a lot of cases, it's pretty much an extension of what the compound is supposed to do anyway. Well, there we are back in Seattle when I was roaming around the streets, and I'm looking at Hypnos there, and he doesn't look too happy. In fact, he looks kind of worried, and I think that's because a lot of people are still having trouble. The medications that we've talked about so far are pretty beneficial for a lot of people. Clearly, they've gone through clinical trials and demonstrated efficacy, and reasonable safety issues that we should be concerned about, but there's just a perpetual hope that there's something else that might be beneficial for people to fall asleep and stay asleep. So, whether it is the prescribers who are looking for something else to give people, patients who are desperate to, try the next new thing that's coming along. Pharmaceutical companies certainly want to have new products to sell. Researchers want to make strides in coming up with more effective and safe medication. So there are a lot of things that are out there that are still being investigated. Some of them are variations of ones that we've seen already. And then there are, as we'll see over the next several slides, there are a lot of new things that are at least being experimented with. Whether or not we'll ever see those products, I don't know. So, well, the moon's good. We should be sleeping usually when the moon is up, but we want to be sleeping, and we want to think about what's new under the moon that might be helping us sleep. And so there are a whole lot of these orexin antagonists that are under development right now. Almorexant was actually the first of these. There was a report way back in 2007 showing the proof of concept of using an orexin antagonist for treating insomnia. Now, this one, like the one available right now, suvorexant, is a DORA, a dual orexin receptor antagonist, and there are a bunch of these that have been looked at. I'm not sure if all of them are still under development, but there's been Phylorexant and Lemborexant. There's an MK3697. And notice this isn't a DORA. This is a 2-SORA, a single orexin receptor antagonist. So there are two main directions where researchers are looking at these compounds either for the dual receptor activity or single receptor activity, particularly with the orexin 2 receptor. There's one called EMPA, which is a 2 SORA. There's this TCS OX229, which has been looked at. A few others. So benzodiazepine receptor agonists, well, we got a lot of them. Do we need any more of them? Maybe there's something that'll be just right in terms of the pharmacodynamics and pharmacokinetics. So we looked at Zolpidem, which is available now. It's got a short half-life, but researchers have thought, what about if we control the release and extend its action a little bit? And we know it's going to wear off quickly because of the short half-life. Maybe that'd be a good idea. So this company has been looking at that as a possibility. Whoa, what if you want really fast action? Inhaled Zolpidem. That would might have certain appeal under controlled circumstances. Everybody wants to fall asleep instantly. So there's research about that pharmacokinetics, dynamics of Zolpidem delivered as a thermally generated aerosol in a single breath to volunteers. I'm not sure if that's going to make it to market or not, but it's pretty interesting. Indaplan has been experimented with for a long time. The FDA looked at it, had recommendations, hasn't been approved at this point. It may still have some life in it somewhere. Lorazepam has been looked at as another benzodiazepine receptor agonist. There's EBT-201 as well. Won't surprise you that there are various melatonin agonists that are out there that are being investigated as possible insomnia medications. There's a controlled release melatonin that is in fact available elsewhere in the world, in the European Union, for instance, but not in the US. Tazomiltone is a medication that is available in the US. The indication for that is for non-24-hour disorder. I think there are some investigations into some alternate indications for that medication. The non-24-hour disorder does involve difficulty with sleep onset for those individuals, mostly blind individuals with that disorder, and so it makes sense that it would be beneficial for their sleep-wake cycles. There's pyromelatine has been looked at, and as you can see, it's not just a melatonin agonist, but has a variety of other serotonin-related receptor activities. There's a TIC-301 that's been investigated. There's UCM 765, which is selective melatonin receptor type 2 agonist. So that's kind of interesting to see what variant of properties that might have. How about beta blockers? So they've been investigated as well, specifically for treating insomnia. Here I was able to find a patent that was taken about a decade ago, the use of a composition comprising at least one beta blocker for the treatment of sleep disorders. And in the details, they were suggesting that they would be probably adding some melatonin to that as well. So I don't know if we'll be seeing something along those lines. No surprise that there might be other histamine H1 antagonists, since it's a familiar property, and maybe there are other compounds that would have just the right combination of properties. So this LY 2624803 has been evaluated for sleep. And really interesting, I think, is this possibility. This is the presynaptic histamine H3 receptor. So an agonist here has the potential to decrease the suppression of histamine release. And so, well, the ultimate effect here is that you can have a net antihistamine effect. There's a tetracyclic antidepressant, which has been evaluated as an insomnia medication, CB2810. There are a lot of different 5-HT2A receptor antagonists. These have been explored for like 10 or 15 years, but none of them brought to market. How about an adenosine receptor agonist? This kind of makes sense. We know that caffeine, which is a stimulant, is an adenosine receptor antagonist. So if we have an agonist, maybe that will be helpful. There's a CGS21680. How about a angiotensin 2 receptor type 1 antagonist? to treat insomnia? Well, it's out there. Here's a patent that researchers took out promoting sleep using AT1 receptor blockers. And, this really highlights the huge diversity of neurotransmitter systems that are being evaluated to somehow try to modulate the sleep-wake cycle. I know nobody's surprised here. Cannabinoid agonist. The research is kind of mixed about the use of cannabinoids to help with sleep. Some people swear by them. Some people say they don't help at all. In any case, maybe there's going to be some combination CB1, CB2 receptor effects that will help. One product that has been looked at, not yet a product, but one compound is this Neo 1940 being investigated for insomnia associated with cancer. Well, I'm just going to switch gears for the last few slides that takes us through this wide diversity of all of these different compounds that are being investigated right now. So it's going to be really interesting to see what comes out over the next few years. So the American Academy of Sleep Medicine in 2008 issued their chronic insomnia clinical guideline consensus recommendations with regard to the treatment of chronic insomnia. And I mentioned earlier that we think very broadly about the treatment and we don't jump right to a medication, although this particular talk is focused on the medications. But in that consensus report, they said the choice of a specific pharmacologic agent within a class should be directed by the symptom pattern. That's certainly true. And again, we have a lot of choices with medications to try to target different symptoms. The treatment goals, past treatment response, if people have used other medications, patient preference, cost, availability of treatments, what comorbid conditions, because that may have a significant role, certainly contraindications, the concurrent medications, because there may be interactions and certainly need to consider potential side effects as well. They also said in that report that patient education is really important, and those issues that should accompany any pharmacologic treatment should include the specific treatment goals and the expectations for the medication, what safety concerns there are, potential side effects, interactions with other medications. Patients should know what the alternate treatment options would be, what potential for dose escalation, if that's something that might be recommended, or if that's something that people may do on their own that might be problematic. And then the potential for rebound insomnia on sudden discontinuation of the medication. They also said that patients should be followed on a regular basis every few weeks in the initial period of treatment when possible. That's really good advice. Efforts should be made to employ the lowest effective maintenance dosage of a medication, to taper the medication when conditions allowed. Chronic hypnotic medication may be indicated for long-term use in those with severe or refractory insomnia or chronic comorbid illness. And long-term use might be nightly for some individuals. It might be intermittent use. It might be as needed use for some people. So here are the key takeaways from my talk today. We should perform a comprehensive evaluation to determine the chief complaints and sleep history, comorbid conditions that possibly affect sleep. We want to develop a broad treatment plan that involves sleep hygiene recommendations, cognitive behavioral strategies, and when employing pharmacotherapy for insomnia, we should use a personalized approach that considers the pharmacodynamic and the pharmacokinetic features of the medication. And this takes us about to the end. I'm going to leave you with this one last slide, which I think is of historic interest and certainly of kind of timely interest as well. This is more historic advertising, and this is from 50 years ago, and I think I'll leave this with you without comment so you can consider the multi-dimensionality of this particular image, which I think isn't popping up here. So I think that's the end of our slides then. I had a slide that had a particular reference to elections, which are on a lot of people's minds these days, advertising from the 1968 time period that related to advertising. So I hope this has been helpful for you. I think we may have time to try to answer a few questions. And I'm looking at some on my screen here. So what somebody's asking, what concerns do you have for long-term use of Zolpidem? So, Zolpidem is a, moderate half-life medication, not too long, not too short for a lot of people. It may not be the best choice, but for a lot of people, it does work reasonably well. So I've gone through a lot of the concerns that we have with any of these medications, including the adverse effects. There can be confused behaviors. There can be ataxia for some people who would be metabolizing the medication slowly, especially if it's a controlled release preparation. There could be problems the following day. I think that most people who will benefit from a hypnotic of this sort will find it useful for a short period of time, perhaps during a crisis, won't necessarily need it long term. I think that many people having this kind of medication available is reassuring, and they don't necessarily need to take it. Having it in medicine cabinet by remote control can be beneficial because at least they may be able to relax and fall asleep knowing it's available, but not really even need to take it. There are people who do take it nightly. There are people that I see who are sleeping well, good sleep quality, are doing well during the daytime, and it seems to be the right balance for them. But I, only do that in the context of closely monitoring people. It's a really exciting time with regard to sleep. And I'm sort of excited about all this research that's going on with the new compounds that are coming along. But I think really the most important thing to think about right now is wise use of those that are available right now. And we should understand the key pharmacologic properties, both the pharmacodynamic and the pharmacokinetics, to make intelligent choices. Rather than using, one single medication for all patients, we should be considering exactly what their symptom patterns are and their comorbidities as well. Somebody asked, what about the effects of insomnia on mental health? Wow. So that's another whole lecture. Obviously there's a lot of back and forth. There's tremendous amount of literature showing that people with persistent insomnia in the future are more likely to develop mood disorders, anxiety disorders as well. We know at the same time that people with mood disorders, say a major depressive episode or an anxiety disorder, they're likely to have worse sleep as well. So it's a kind of a two-way street. The degree to which we can address the insomnia symptoms, whether it's through behavioral strategies and sleep hygiene, possibly the use of a medication, that's likely to be beneficial. A little bit of research actually shows that people's depression scores are better when they're sleeping better with the use of a hypnotic medication. But clearly it's a very important interaction. Another question here is many of my patients are under the age of 18. Many of them have issues with sleep problems. What's the medication preference in these patients? So under 18, well, that's a whole lot of ages right there. There are, some in their later teens that may be appropriate for adult, prescribing guidelines. And then there are the, 3, 4, 5, 6, 7, 8, 9, 10-year-olds who are under 18 as well, who you may want to address very differently. I can say, rather than jumping to an answer about a medication, I want to say that we need to step back and look very broadly at a lot of different issues that might be contributing to the insomnia. And this will give me the opportunity to say, that includes looking at sleep disordered breathing. I have a very low threshold for evaluating people for sleep apnea. Because it's so common. I see a lot of people who come into our clinic very specifically complaining of insomnia, and it turns out that it's obstructive sleep apnea causing their difficulty. It certainly is true in children as well, who do very well with tonsillectomies. So, evaluating potential snoring in that population would be important. It's frustrating, and I'm sympathetic to the person asking the question because there really aren't sleep medications that are officially approved by the FDA for younger children. So a lot of things do get used, a lot of diphenhydramine, a lot of clonidine is prescribed. There's not a great answer, and I think really important is looking at the environment. And one other thing about this particular age group, at least the teenagers, is the tendency for them to be somewhat phase delayed. biologically finding it easy to stay up late and then sleep late the next day, and the degree to which we can help manipulate the environment to minimize too much bright light exposure in the evening and use those blue blocking apps and maybe even blue blocking bulbs, reddish bulbs that are so readily available to help decrease the environmental influence that promotes people, staying up too late. There's a question here. How likely are you to prescribe medications for patients who do not comply with sleep hygiene recommendations? Well, that's a tough one, isn't it? It depends on what the person is doing and how bad it is. The ideal sleep hygiene recommendations could be pretty strict about people getting up at exactly the same time, going to bed at exactly the same time, having meals at the same time, and preferably having the last evening meal several hours before bedtime and avoiding other food after that. Then there are all the other issues with alcohol and would like to stop cigarette smoking and well, in any case, I think there's always some balance there. I'm not likely to prescribe a hypnotic medication for somebody who is wanting to use that just to make up for other problems in their sleep wake schedule. And I don't see any other questions at this point, and I think that probably brings us to the end of today's presentation, and it's really been enjoyable, and I hope it's been helpful for you.